Introduce a wonderful young researcher, Dr. Daniel Halperin from MD Anderson, to talk a little bit more about the work we're funding with him and some other exciting developments. Dr. Halperin.
So thank you everyone for having me today. It's a pleasure to be here. We're going to talk about a couple of disparate things. We'll touch a little bit on the epidemiology of neuroendocrine tumors because it's been a major focus in our group, but really sort of springboard from there into some of the work we're doing that's been generously supported by the NetRF, looking at some basic insights into the immunology of these tumors and why we're so interested. So we'll start with those epidemiologic data. We're going to talk a little bit about the history. I want to tell you a story about why we think immunotherapy is just so darn cool and why we think it's going to be a major breakthrough in this field, and we're investing so many resources in that direction. And then we'll show a little bit of those data, just a little bit of a teaser to get everyone interested. So I thought I would start with sort of a stratospheric view of our NET program at MD Anderson because it gives you a sense of why we're doing the things we're doing and how the different things I'll tell you about relate. So as you can see, in the middle of everything is the doctor and the patient, and I'm still confused about why in this free graphic they're both smiling, even though one of them is hitting the other. But I do think that this really is the core of everything that we do, and drives us to ask the right question at the right time in the right patients. As you'll see, we do some very high-level epidemiologic work looking at populations of patients, trying to understand where the need is, define the scope of the problem, and understand where interventions can be deployed. And in parallel, actually, exactly as Ron was just saying, we amass tissue specimens from our patients who generously donate them after we're done with the diagnostic pathology material, allowing us to start to get some of these translational insights. And it's only because we have hundreds of patients who have been willing to work with us over the years that we're able to put together a bank that lets us power the projects that we're going to talk about. And of course, a big component is clinical trials. And you notice here, this is actually my artwork everyone's smiling in. That's because we think all of our patients are happy on our clinical trials. But as you can see, all of these things feed into each other. So the tissue insights drive the clinical trials, and the clinical trials provide more tissue, so we figure out how the drugs work, which we'll touch on a bit later. So as you saw earlier, I believe from Dr. Hendefar, neuroendocrine tumors continue to rise in incidence, and these data are now a couple of months old in terms of publication. But as we see, we're now approaching about 7 people per 100,000 population per year in the States, driven, as we've expected, by lung, small bowel, and rectum predominantly. But what's interesting is that, in fact, with some improvements in therapy and survival, the prevalence, so the number of people living in the country with this disease after diagnosis, is growing dramatically over the last 20 years. And we think that's not only due to the rise in incidence that we're seeing, but also some survival advantage from all of the new therapies that we've brought to bear. Now, in parallel, we also do some very high-level analyses doing something totally new, which is looking at, can we use claims data and population-level data to understand something about the scope of the problem of carcinoid syndrome? And just as a teaser, I think this is a little bit related to the other things we're going to talk about today, but we're not quite there yet in terms of data for me to tell you how. But what we've noticed is that we can go to these high-level population databases, 10,000 patients across the country, across decades, and actually observe those trends that we've always thought were there over time, that grade, stage, primary site relate to hormone function, and that these things are actually relatively constant as over the more recent 5 years or so. But as interested as we all are in defining the scope of the problem, we're all really interested in what comes next. And so I want to tell you a little bit of a story about how we got interested in the immune system and neuroendocrine tumors. So this starts with streptozocin, which, as Dr. Hendefar described temozolomide earlier, this is another alkylating agent, chemotherapy. It's in fact the original chemotherapy for pancreatic neuroendocrine tumors that almost no one uses anymore except for us. And what I think everyone in the field knows is that this is a chemotherapy where regimens have been observed to induce some responses and improve progression-free and overall survival, leading to FDA approval many years ago. But actually, around the same time as the original studies were being done at the NCI, the early 1970s, the diabetes researchers started to notice that if you give this chemotherapy at low doses 5 days in a row, you'd induce T cells, the immune system, to go in and attack the normal islets. And this is actually a great model of type 1 diabetes. And it just occurred to us that we actually give this chemotherapy at low doses 5 days in a row to human beings with neuroendocrine tumors from the islets, and something happens and the chemotherapy seems to work. And so we got curious going back 5-6 years ago, wondering, could it be that some of our other therapies are also immunomodulatory, and is there something deeper going on? And it turns out actually that there's at least one other therapy. Temozolomide has some data as well, but sunitinib, which was one of the recent therapies approved now about 5-6 years ago by the FDA, again for improving progression-free survival in patients with advanced pancreatic neuroendocrine tumors, that also has a well-described immunomodulatory function. And sunitinib, like other VEGF inhibitors, has been observed to deplete immunosuppressive regulatory T cells. And this has been observed with bevacizumab, another VEGF inhibitor, as well as sunitinib and others, all of which as a class we understand to be effective in this disease. And so it struck us that it might just be the case that there's a couple of different therapies out there that are weak immunomodulators that actually turn out to be effective. And so many of us for several years have been trying to get this more modern, what we call checkpoint inhibitor immunotherapy, into the clinic to see if it would be more effective. And as I believe you heard earlier, there's a recent study that's been launched of a medicine called PDR001. This is a PD-1 inhibitor, so it blocks essentially a suppressive signal between tumor and T cell, or other stromal cell and T cells. And about a year ago, the first clinical trial response was reported. And what we love to see in the clinic is that actually after the immune cells rushed in and caused the tumors to swell, they shrunk, and you can graph that nicely using the RECIST criteria that everyone heard about earlier. But what we love to see in the lab is that at the same time, after just 4 weeks of therapy, you see this bright brown stain as the T cells rush into the tumor and attack it. And this isn't common. We don't know how common this response rate is. That's why there's a prospective clinical trial that's ongoing right now that City of Hope and MD Anderson and many other centers around the world are participating in, looking prospectively at this single agent drug to understand what the effectiveness is in this disease. But I think we recognize that added into this empiric environment of trying drugs and seeing that they work, we need to add some enlightenment. And so thanks to NetRF, we've been able to start looking at the immune environment of these neuroendocrine tumors. And what's important to note here is that this isn't the first time people have been interested in the immune system. In fact, if you go back over the last couple of decades, you'll see a paper here, a paper there. This immune cell is bad, that immune cell is good. But this is very much, it's people touching that metaphorical elephant. Everyone has sort of part of it, but no one can really describe the whole thing. And that's what NetRF has allowed us to do, is actually look wholesale across multiple different immune cells and checkpoint markers in a population of patients with advanced pancreatic neuroendocrine tumors to try and characterize what the whole environment looks like, because it's never just one cell. It's this very dynamic interactive network of cells that regulates the immune system. And what we can start to see is that in fact, if you look hard enough, there are T cells in these tumors. And what's very interesting to us actually, given our initial hypothesis, is that there aren't a lot of regulatory T cells. You notice how skewed this population is over here. So those suppressive cells weren't as prominent as we expected. But we're seeing a few more macrophages than we expected. And as we put these things together with all of the other stains that we're doing, I think we'll start to have a story come together, and we're still hanging on to our original hypothesis that that VEGF, that vascular growth factor that is blocked by bevacizumab and sunitinib and those other drugs that I mentioned, may be having a major role here. Now, this is particularly interesting because several months after we launched this study with NetRF, some really neat data came out of Gabrielle Berger's lab, originally at UCSF, but I believe she moved. And this uses one of those sort of mediocre models of neuroendocrine tumors. It's a RipTag mouse that's p53 dependent. But much like we understand about pancreatic neuroendocrine tumors in people, there's absolutely no PD-L1 expression at baseline. And as we know, this is one of those checkpoints, right? Part of that sort of suppressive signal. And many of us were a little bit distraught when we saw that there was none there. But what's interesting is that as you block VEGF in these tumor models, and actually several other models of other tumors, the PD-L1 expression starts to go up. And what's really neat is that when you block both in combination, you start to get formation of these vessels. and an influx of T cells that actually helps the mice with the tumors live a lot longer. And we thought this was fascinating, not only because it was consistent with the same hypothesis that drove the NetRF grant, but about 2 months before this paper came out, we'd actually opened a combination study of VEGF inhibition with bevacizumab in combination with PD-L1 inhibition with atezolizumab. And this was done under the auspices of our rare tumor working group, where a bunch of us got together and happened to think this was a worthwhile combination. And so we put this together, and I happened to be leading the study by sheer force of luck. But what's really critical about this study is that not only do we have the empiricism of trying this new combination and seeing what happens, but it actually, as part of this, our patients have partnered with us, and we include biopsies on treatment and before treatment to see if the drugs do what we think they really do, so that we can expose as few people as possible to these new therapies in order to figure out if they're working the way we think they are. So, in this very brief snippet to try and get us back on time, I've talked to you about a couple of things. We've looked at that very high-level epidemiologic data, again, sort of justifying all of the work that we're doing, demonstrating the scope of the problem as neuroendocrine tumors continue to rise in incidence and prevalence. We've talked a little bit about carcinoid syndrome and some high-level data there. And then, really, I've tried to tell you a story about why we're so excited about immunotherapy, that this story actually goes back decades if you look carefully enough. And right now in the lab, thanks to that support from NetRF, we're able to sort of look and try and understand if we can shine a little light on this story and understand what targets there are and what targets we should be hitting, so that as we move into the next generation of immunotherapy studies, we're pushing in the right direction. So with that, we have a huge team at MD Anderson, multiple medical oncologists, multiple translational pathologists, a huge genomics group, all of whom are working together to get new therapies into people who need them as quickly and safely as possible. And truthfully, none of the rational design and combination therapy would be possible without the support of NetRF. So with that, I just want to thank everyone for their attention, and I'll be happy to take questions at the end in the faculty panel. Thank you.